morning to everyone. It's a pleasure for me to introduce this talk about the new technology, low-level light therapy, that as you will see during this hour together, is a very interesting new technology for treating a variety of diseases. This morning we will talk about ocular surface disease and dry eye, but you can see in the upcoming days also other potential applications of this technology. I will do a part of this talk. Sarah Farrant, she's an expert of dry eye and ocular surface disease. She's ambassador of TIFOS, that is the most important society on dry eye worldwide. Will talk with me about other potential application of this technology. So I had the opportunity to use this technology since the last 3-4 years. And in these years, I collected a lot of data. We published a lot of papers. Some of them you will be able to see this morning. And the importance of this technology is not only the mechanism of action, it is original. You can see how it works at a cellular level, stimulating the production of ATP and stimulated the proliferation of the cells. But the other important thing from a clinical perspective is the immediate relief of symptoms that is able to procure to patients who receive the treatment. I think that this is a very exceptional fact for an instrumental device for dry eye disease. All of you, if you have used in the past other instrumental devices for dry eye disease, the disadvantage is that during the procedure they can procure pain or irritation. With this technology, you are able to alleviate symptoms starting from the treatment session itself. And I think this is a unique opportunity. The main characteristic of this type of light is that it is monochromatic, and the waves are different and can, as we will see, target different cells. In contrast to laser that conversely have a single wavelength that have a spatial and temporal synchronization. So, as I said before, it works at a cellular level and it is able to stimulate the production of ATP and so stimulate the metabolism of the cells that are in the eyelids, are in the conjunctiva, are in the peribulbar zone. So all these cells that are damaged by trauma, injury, aging can be stimulated by this treatment. So after this brief introduction, I take the microphone to Sarah Farrant, who will talk about application of this technology in blepharitis and other ocular surface disease. Thank you.
I really want to talk about my own experiences in practice with using the technology. But to just step back a moment, we really have to think about dry eye as a disease. And as a consequence, it's so important to actually engage with it properly as clinicians and actually manage the issues that these patients face. And in fact, in the words of the World Health Authority, they have clearly marked it as a big underestimated disorder, one that really does need proper attention. So we typically encounter a range of symptoms with dry eye disease, often including variable vision, including burning, stinging, redness, gritty sensations. These are all the classic symptoms that patients would complain about. But also there are many risk factors. And indeed, the TIFOS new lifestyle report that was released just earlier this year tries to look at the impact of other lifestyle factors like pollution, like air conditioning, like contact lenses and cosmetics, all these things that really do have quite a bearing on what happens with their dry eye disease. So in 2017, TIFOS came up with this sort of protocol of how we can think about diagnosing and working up our dry eye patients. And it really is a very useful, simplified way of considering the mapping and the journey that we need to follow as clinicians when we're working up these patients. What it also really importantly identified was the fact that we historically thought about dry eye disease as being sort of either evaporative or aqueous deficient. And this is really the first time that we decided, no, really it's a mix, it's an amorphous blend of the two processes. And we actually find from many studies that we think about 80% or more of dry eye disease cases that we encounter are actually primarily evaporative in origin. So when we're treating and thinking about what we're going to do to engage with these patients and achieve success, there are a few things really that we're fundamentally trying to alter. So we're really wanting to control the inflammation and regulate the biomarkers on the surface. We also need to make sure that we try and improve the secretion and functionality of those glands, because we know that 80% of the dry eye disease patients we're going to see are likely to have issues with their glands. We also want to make sure we try and calm down and reduce the bacterial load. Many studies tell us that the bacterial load is affected in dry eye disease, but until now we've maybe not really thought about the ways in which we can actually calm down that side of the problem. We need to look at the tear volume, try and regulate that and improve the osmolarity of the surface. And also we really want to try to also bear in mind the nerve element, the pain pathways, which I still feel is quite under-regarded when we're considering the neuro pathways of how we manage these patients when they've had sort of sensitization issues in their nerves, both peripherally and centrally, and how we try and start to engage with those patients better as well. So this is just a summary of the sort of treatments that I follow in my usual clinical practice. And as you can see, I've really split this into the sort of treatments that I would be recommending in a written protocol, a written treatment plan for my patients to take away. And that includes the classic things like warm compression, but it also includes things that are a little more sort of on the newer radar, as it were, like cosmetic use and all the chemicals that can influence the ocular surface in cosmetics, and also things like your diet. So starting to think about like the buzzwords like ultra-processed foods and how that has a role in inflammation and gut health, and the implications of that more holistic approach to dry eye disease. So when it comes to my in-office options, wonderfully more than ever, we've got a broad range of options that we have now as clinicians for engaging in treatment for these patients. So that can be from simple gland expression. For any of you that have maybe seen videos online, I'm a big fan of squeezing. I think it's really important to drain the meibum out of glands, whether that's both from a diagnostic workup point of view, but also from a therapeutic point of view. We know that it helps to just flush all that viscous meibum out of the glands. And then we've got the various options, so cleaning the lids, IPL, low-level light therapies, puncture plugs, and all the range of things that we can now engage with. And obviously then we've got the treatment options, the therapeutic drops and things that we've now got access to, and an ever-increasing list in our armory, as it were. So, as we mentioned earlier, the fact that we really need to engage in about at least 80% of these patients are going to have issues with their glands. And we know that alters the lipid layer thickness, it alters the tear quality, and all the knock-on effects that has. So IPL, what it is basically a polychromatic light, okay? And the thermal impulses of the light are basically regulated at just the right range and just the right intensity to perform at their most effective. We know from studies that the wavelengths used in the light are shown to be effective even after 6 months, okay? So the way we use it, we apply the IPL in a periorbital area in 5 treatment zones. It's very simple to do in practice and really doesn't take very long to achieve. It is effective alone, but again, being a squeezer, I always like to drain those glands down with expression every time I've done IPL therapy in the clinics. So there are a range of theories at the moment as to why IPL actually works, as it were. And the list is quite long as to what we think it helps to achieve. So we've got the more obvious things like the thrombosis of the abnormal blood vessels, and this is the origins of its use in things like facial rosacea. So we also know that it heats and liquefies the meibum, and that's also why it's so advantageous to squeeze the glands after, because you really can drain all the contents out. We know that it also reduces the bacterial load on the lids, helps to reduce Demodex count, helps to break apart that inflammatory cycle, the cytokine release and things on the surface. We also know that it can help influence the levels of oxidative species on the surface too. So when it comes to the actual practicalities of applying IPL, there are some risks that if you effectively have the direct IPL source on eye, then it can cause things like iris atrophy and anterior uveitis. So you have to shield the eye, okay? And you can do that with goggles, or you can use the sort of sticky patches as well. So the nice thing about the Espansione system is that it's using this unique low-level light technology. Okay, so alongside the IPL system is low-level light, and in the clinic, it's really easy to do. You don't even have to be in the room with the patients. So this is a delegated function in my clinics. The patients lie in a reclining chair. They stay there for 15 minutes. They listen to a podcast. They just have a really quite nice time with it. It's completely painless. And immediately after, the patients are getting tangible sense of relief and improvement, which is always nice to sort of get that slight miracle moment, as it were. It's very easy to use, it's safe, and you literally can just leave them in a room cooking, as it were. We know from studies, thermography comparisons, that the data immediately after IPL versus low-level light therapy shows this endogenous heating of the skin, which is more impactful, and low-level light has a higher efficacy as a result of that as well. So this study released earlier this year by D'Souza looked basically at the efficacy and safety of low-level light therapy and IPL combined. So we found from this study that the cumulative effect of sequential sessions, so they did three sessions about 2 weeks apart, and found that the OSDI scores improved significantly over both 1 month and 3 months compared to the control. And also we showed that the non-invasive breakup time also statistically improved. So we know that the sort of cumulative effect of the sequence of therapies has good results. And the study also highlighted the fact that there were no adverse effects at all. It really is a very safe procedure to conduct. Further study here, Nicastro, had a look at the differences between different IPL units, okay? So this study particularly compared the eye light with the E-eye and the Therma eye, okay? And it really highlighted that there are differences between different manufacturers of these units. So we know from this study that it produced a result that showed that any patient with a poorer score, a higher score with the OSDI and a worse lipid layer thickness, those were the patient groups that benefited most from having any kind of IPL therapy. Okay? But what this study also showed, really interestingly, that even after they'd concluded their treatment at week 3, when they were measured at month 6, they went on to still have further improvement in their OSDI scores. Even though the treatment had concluded at week 3, it continued to improve the ocular surface over time with the OSDI score. We also saw in it that the lipid layer thickness was assessed, and again, all groups improved, and again, we saw the eye light performing well at the month 6 period. So it really does have a lasting effect on these patients. And typically in clinic, once I've done that cumulative effect and built up that initial treatment, then I'm seeing the patients roughly every 6 months to do just top-up sessions on them, and that just seems to keep them at that much better place. So this other study had a look at comparing IPL and low-level light therapy with eye drops, okay? So the group that were in the eye drop use were using drops, I believe, 3 times a day for the full duration of the study. And what it highlighted was that using drops is good, it helps, it reduces the OSDI score and improves the breakup time. But what it also highlighted what the group that were in the low-level light and IPL treatment group were the impact of the OSDI score and non-invasive breakdown was better, and that was maintained at 6 months. So it was a significant difference between the groups that were just on drop therapy, and that's even putting drops in pretty regularly 3 times a day. So this is a video, I hope you can see it, just highlighting the lower lid, the tear prism there. And I just wanted to start to talk a little more about saponification. And in this study, we've actually got a region here where we've got saturated meibum. Okay, so when you have meibum gland dysfunction, the fats tend to become more saturated. And as a consequence, they don't mix as well with the tears. Okay, so you also get what we term in the UK lipid bergs, like icebergs of fat, okay, sort of swimming around in the tear film. And in amongst this clump here, there's just a tiny little bubble, okay? So you have to try and differentiate as a clinician, well, what's just saturated meibum, just sort of stagnant in the tears, and what's foam, okay? Because it means something quite different. So when bacteria have a good food source, they proliferate, okay? And bacteria prefer saturated fat. So in a dry eye state, the meibum that's being produced is more appealing to bacteria, okay? So that's part of the reason why the bacteria are able to overcolonize, and obviously the eye is warm and moist, and it's a great place for them to be. So once they hit a certain level, these bacterial colonies secrete something called exotoxins, and they often are triggers for things like the classic marginal keratitis issues that we see in dry eye patients. Okay, and the problem with those exotoxins is that they also feed into the inflammatory cycle. Okay, but what we also see is that bacteria secrete enzymes. So common bacteria, Staphylococcus, secretes an enzyme called lipase, and lipase intentionally starts to break down the lipids in order for them to basically ingest it better. Okay. But the problem with that breakdown is that it actually produces a process called saponification, which is basically like having a soap factory on your lid margin. Okay, so the bacteria being present break down the meibum into what's in essence soap when it mixes with the alkaline tears. So that surfactant has exactly the effect that you'd imagine a surfactant would have on the tear film. It breaks down the lipid layer, so it further destabilizes the lipid, further destabilizes the entire system, and promotes that sort of continued inflammatory cycle that we're all so familiar with. So this image is more highlighting, you can see the lipid bergs in the tear prism here. So these are just sort of free flowing in the prism. But you can also start to see saponification. So this is a very mild case of saponification. You can see the bubbles, okay? So some are free in the tears, and mostly saponification sort of sits and the bubbles stay on the lid margin. This is a much more extreme case of saponification. So you can see just the level of bubbling and frothing that you're seeing in the tear film here, okay? So what do we do about these? Well, one of the issues is that it's feeding a cycle. So we know that blepharitis patients have about a 14 times increase in bacterial load, okay? We know that those bacteria, like we said, secrete those exotoxins, they secrete those lipase enzymes, so it's all sort of compromising and inflaming the surface. So the biggest issue is it's a cycle, like so many things in dry eye disease. So how do we break it? The other problem with Demodex being present is that Demodex are also vectors for bacteria. Okay, so they carry bacteria on their surfaces, and obviously they move around and act as a host as well. That's just an image for those of you who have maybe not seen them. This is me just pulling a collarette away from the lid margin and exposing 3 Demodex tails just on the surface there. So this is now a case in my clinic a few months ago of a lady who came in. She'd already been listed for cataract surgery. She was complaining of sore red eyes to her GP, and in the UK, GPs love giving out chloramphenicol just as a broad spectrum sort of soak everything up mantra. But she had a marginal keratitis here, secondary to her blepharitis issues and her saponification issues. So she was put on a tapering dose of Maxitrol. And then when I saw her 2 weeks later, obviously the marginal keratitis had significantly improved. So what we were dealing with clinically was a case of Demodex blepharitis. She had telangiectasia on her lid margins, and maybe you can see some gland plugging there. And as I mentioned earlier, I'm a big fan of squeezing. So when I got out my forceps and started pressing the glands, you can see just how viscous the meibum is, okay? This alone helps them symptomatically. So it's also very important to start to do this if you're not utilizing it in your clinics already. And you can see here her level of saponification, okay? So you tend to look at saponification along the lower lid margin towards the sort of temporal aspects. So it usually sort of sits just along the margin there. So these were the results from her evaluation. So because she'd been treated with Maxitrol just on the left side, it had already, just in 2 weeks, significantly improved her tear breakup. So that's why the tear breakup time on the left eye was so much better. Also looking at meibography, most of her meibum glands are intact, but you can see there are some pockets of loss of integrity of the glands. So in the clinic, we came up with a sort of working diagnosis of Demodex blepharitis, meibum gland dysfunction, a tendency for marginal keratitis, and an excess microbial load. Okay. So what we basically decided to do to her in practice was a microblepharoexfoliation procedure, just to debride all the lid margins, get rid of all that Demodex collarettes, and just sweep the slate clean. And often I use the analogy with my patients like taking plaque off your teeth. Okay, it just resets the bottom, as it were. We also then planned to conduct IPL, 4 sessions of that, alongside 4 sessions of both near-infrared low-level light therapy and shortwave blue therapy to deal with the saponification. Okay. So then we instructed her very carefully on a treatment for her to follow at home, which was basically warm compressing, omega-3, some lubricant drops, and some Blephar-Demodex wipes with tea tree, terpinol to diminish the Demodex count. So once she had completed that for 4 months, so we put her through the course. This was her 6-month review, as it were. You can see on hard expression that the viscosity of the meibum is much, much improved. And bear in mind, this is 6 months after I did that loading dose of light therapy. You can also see here, having done the shortwave blue therapy, that she now literally has no saponification at all. Okay, and again, you're sort of looking at, I think, 6 months after we finished. This is it's very sustained, the effect, and obviously she was much, much happier with how her eyes were performing and much more comfortable too. So the sort of plan moving forward with her was to keep the strategy of reviewing her in the clinics every 6 months, with top-up sessions of IPL, top-up sessions of low-level light therapy, and getting her to continue with her OSDs regime at home. So this is the general protocol that Espansione have devised for using the light therapy. So in terms of when we have meibum gland dysfunction or when we have blepharitis, there are 2 concepts of different protocols to follow. You can see the blepharitis recommends use of the shortwave blue therapy to engage with that bacterial load issue. So typically we would want to apply a strategy of using at least between 2 and 4 repeat cycles of treatment, and then frequency-wise, they should be something like 5 to 10 days apart. If you want to know more, or indeed have a further review of the studies that we've mentioned in the talk today, you can download them, or I believe they are available at the booth here as well.
Okay, thank you, Sarah. So we saw a patient with active blepharitis, with marginal keratitis, with active inflammation, that came to her office for receiving cataract surgery. So in that case, you have to treat the patient before doing surgery in order to avoid serious complications after surgery. This study is performed in a different setting of patients. So in these cases, we have a patient with a healthy ocular surface, who have only senile cataract. They have a normal ocular surface, and we want to treat them prophylactically in order to avoid to develop post-operative dry eye. in fact, we know that if you do a good surgery, even in a healthy ocular surface, you can determine signs and symptoms that affect the patient's quality of vision and life after surgery. A lot of different parameters and factors are involved in this cascade of events, from the speculum to the incision to the microscope lights and postoperative preserved therapies. So all these factors contribute to the development of this complication. We want to avoid this complication because it affects the patient quality of life, but also quality of vision. So these are the well-known unhappy 2020 are patients with a full visual acuity that are not satisfied with their surgery. And this is a very high percentage of patients. So we need something that is able to prophylactically avoid the onset of this postoperative complication. The mechanism of action of low-level light therapy, you have already saw it. And as I said before, this instrument, I think, has the wider amount of scientific publications that confirm its efficacy. There is a lot of papers. This is published from our group in cornea a few years ago. This is another on scientific reports, but a lot of papers confirms the efficacy in dry eye patients. I will present now the data that will be discussed on Monday in a session of the Congress that is focused on preventing dry eye disease in patients otherwise healthy undergoing senile cataract surgery. So this study was conducted in the University of Catanzaro in Italy a few months ago. It was registered on ClinicalTrials.gov, and we have already submitted it on British Journal of Ophthalmology that accepted the paper with minor revision. So I think that you will be able to read the paper very soon on PubMed and on social media and Espansione website. So, as I said before, we excluded all patients with previous dry eye. We know that patients with previous dry eye has to receive an intense protocol like that one showed by Sarah. In these cases, we have patients with healthy ocular surface, and in these cases, we want to prevent dry eye. These are all our workup that is mainly based on keratograph, but Espansione has other also imaging devices that can assist you in the diagnosis of dry eye. And this is the protocol. So we treat the patient for 15 minutes with a closed eye with the mask, and we randomized the patient in two groups. One group received the conventional treatment. One group, the control group, received the shunt treatment. Shunt treatment is a very low power output of this technology in order to ensure blinding for both patient and examiner. So in this way, we don't know if the patient is receiving a normal treatment or a shunt treatment, and we can have a real double-blind clinical trial. This is the list of patients included. We assessed a lot of patients, more than 600, but we had to exclude more than 500 of patients because many patients who come for routine cataract surgery have diabetes, have autoimmune disease, received already surgery, or use glaucoma or other medications. So we excluded all these patients, and we worked only on patients with healthy ocular surface. Out of these 654 patients, we randomized 153 patients and randomized to treatment group 66 patients or control group 65. This is the protocol. So 1 week before surgery, patient underwent or LLLT treatment or shunt treatment. Then we did surgery, and then 1 week post-operatively, patient underwent again another session of treatment or of sham. 1 month post-operatively, we evaluate the patient in order to ascertain if ocular surface parameter improved, worsened, or remained stable. This is the characteristic of the patients that were included in the two groups. They have no difference for age, for gender, so the randomization allowed us to obtain a similar parameter for both groups. These are the main results of the study. You can see the group, treatment group or control group. You can see the time points, 1 week before surgery, 1 week after surgery, 1 month after surgery. And you can say how, for each group, one parameter, for example, symptoms, changed over time. So you can see how, despite this patient received surgery, we know that surgery determines a worsening of ocular surgery, of ocular surface parameter. Despite the patient receiving surgery, patient treated with low-level light therapy improved their symptoms. So we had so our treatment was able to counteract the effect of surgery, and despite surgery, patient improved the ocular surface status. And this was valid for the two main parameters of dry eye, that are symptoms and that are non-invasive break-up time. You can see that in the control group you did not have the same result. So I think that this is the most significant result. The normal course is the worsening of these parameters. If you treat prophylactically 1 week before and 1 week after surgery, you are able even to improve ocular surface disease. So this is the main take-home message of the study. You can treat the patient even if they do not report symptoms, even if they do not have signs of dry eye. You can have improvement of symptoms and of break-up time, that are the two main parameters in the setting of dry eye disease. Infrared mammography had some fluctuation during the study, but we know that to have significant changes in meibomian gland anatomy, you need more time. You need several months in order to revitalize glands that are atrophied. Which are the limitations? Maybe one limitation could be OSD. You know that ocular surface disease index is the most important and validated questionnaire for dry eye. The main limitation, it is influenced by visual task. So patient with cataract surgery has an impairment of visual acuity, so this can affect the result of OSD, but the difference from baseline to 1 month postoperatively was so high that we are confident that this improvement is consistent with the effect of the therapy. The other issue, and we are continuing studying patients, that we evaluate them after 1 month, but this symptom can occur even later. But as Sarah said us, these therapies have the advantage to provide a prolonged advantage over time. So we are confident that this result obtained 1 month post-operatively can be maintained over time up to 3-6 months post-operatively. So to conclude, we know that signs and symptoms of dry eye are a real problem in the setting of cataract surgery. We showed that 2 sessions of low-level light therapy, 1 week and one week before and after cataract surgery, are able to ameliorate tear film stability and ocular surface symptoms. And the most important thing, one of our reviewers asked us, why did you treat the patient 1 week before and 1 week after surgery? It's a very interesting question. We decided to use a protocol that could be incorporating in the normal workflow of a patient receiving surgery. Usually doctors see patients, for example, 1 week before surgery to do biometry, to collect signatures, and so on. At that time, you can do the first prophylactic session. Then 1 week post-operatively, usually patients come for a routine control visit. At that time, you can repeat the second session. As Sarah said, you can activate the mask, you can leave patient in a chair, and then come back 10 minutes later when the treatment is finishing. So the real importance of our protocol is that it can be incorporated in the normal workflow of patient receive cataract surgery. So we think that it could be replaced in all settings, in all kinds of patients who is scheduled to receive this kind of surgery. Thank you.